Hi everyone, Alison Davis. I work for the Birmingham Cancer Network currently for the next perhaps 6 weeks until we move into the strategic clinical networks, which will be taking over kind of similar work. Worked in their service improvement team for a while, and I'm going to talk to you today about one of the large pieces of work that we've done, which started with one of our district general hospitals and quite quickly spread across our entire network. So we were asked to go and have a look at a piece of work in one of the hospitals with a cohort of cancer patients that suffer a condition called a Metastatic Spinal Cord Compression. For the non-clinicians amongst us, it's when the cancer on the spine compresses on the spine. The early signs of this condition are very similar to the signs and symptoms of their cancer anyway, their metastatic cancer. Pain across the back, which turns into numbness and eventually loss of limbs, usually their legs, paralysis. In the early days when I went in, the problems were that these patients weren't presenting very early and they weren't being picked up in the hospitals, in the A&E departments. It's quite a rare condition, but it does progress very quickly, so the outcomes are very low for patients if it's not picked up early on. So I went in to have a look at what was happening, talked to some patients, had a look at some case studies, talked to the staff there, and got a champion in that trust, which was the nurse consultant who had just been appointed as MSCC coordinator, so it was her work as well to try to improve the pathway for these patients. We have 6 general hospitals in our area and 2 treatment centres. So one centre, different hospital, different trust is responsible for the radiotherapy of these patients, and if they're lucky enough to get caught early enough to have surgery, that's yet again another hospital. So a lot of kind of communicating, swapping patients over, etc. That's needed for these patients. Oh, excuse me. So the first thing that we did when we started working with them was to have a look at what was actually happening. So we walked the patient journey. It was actually the first challenge before we could walk the journey was finding the patients. There was no code for MSCC, there was no knowledge about how many patients they'd had with MSCC or with suspected MSCC. No real understanding of this cohort of patients at all. It is a condition that can affect non-cancer patients. There was no understanding of how many were cancer patients, how many were non-cancer patients. The acute medical staff had very little information at their hands about what to do if they had these patients. Imaging departments had no prioritisation for the patients at all. So there was, kind of a lot of mess for these patients, which hence that first picture, it should be a nice straight path. It wasn't. It was kind of like, oh, we'll go from A to B, but we'll go via C, D, E, F before we can get there. And that was what was happening. So once we found some of the patients, we walked their patient journey and had a look at what was truly happening for them. We held a patient focus group for the acute emergency admissions in the hope that we would pull some of the MSCC patients out of there, which we did, and we learnt some really valuable things from the patients there about what was currently happening to them. We did a lot of process mapping with different departments, different areas, pull some real value streaming out of those process mapping. The other area that was causing problems was the MRI process, not only the referral into MRI and the acceptance by the imaging department, but the transfer of those images then over to the treatment centres. If you talk to the district general hospitals, they'd say, well, we sent them the images and they keep saying that they haven't got them. And if you talk to them at the other end, they're not there and they're not having them for their MDTs or for urgent assessment by their surgeons or their oncologists. So it was important very early on to involve all the specialities across that hospital and then touch into the specialities within the treatment centres as well. So we started to kind of, I think very early on I realised that it was going to be a lot of a bigger project than we initially thought. So we linked in with the Trust Acute Oncology Group, which part of the MSCC links into them anyway, and decided then to start talking to the rest of the network about this work. There were some very early wins that we had in the trust that we were working with just from having the MSCC coordinator on board, and that was talking to the community staff that were working with these patients to try to bring them in earlier, starting to do some education and awareness in our acute medical unit and with A&E. And we realised that by involving the other centres across the network and spreading the work that we were doing, we would actually have kind of a much bigger scale improvement going on. So we have a network site-specific group that we run from the network, which brings all the trusts together and people that are kind of professionals that are involved in this pathway. So we jumped on the back of that group and asked them to support us with the wide-scale improvement. We ran through them a local education event where we invited people from the region of all specialities to come and start some conversation really about we've had a look at this is what we've found, there's some real problems going on, these patients are getting poor care, identification is really poor and therefore the outcomes are poor for these patients. They're not improving from coming to hospital because they're coming too late and the hospital aren't responding quickly enough. So we had a very successful event that we held at the Royal Orthopaedic in Birmingham where we had surgeons, radiotherapists, oncologists, nurses, support staff, and we got them all into rooms to talk about what's happening. Let's not kind of do this individual, let's have a look at whole-scale improvement. And this was kind of one of the things that we came up with. We decided that it was a real big project that we had ahead of us. You could have been daunted by 6 hospitals. If any of you have done any service improvement, you know how difficult it is to do improvement that scopes 2 different departments in one hospital. So to scope 6 departments in 8 different hospitals was quite a challenge. So early on we decided we had to break it down into sizable chunks, and we had a look at the NICE guidance that links in with this work, at what was expected, and we categorised it into different sections. So early detection, what did we need to do to make sure that we picked up suspected MSCC in these patients at an earlier point to give them a better chance of positive outcomes. Early diagnosis, once they're in the hospital, what could we do to make sure that hospital staff are equipped to pick it up and to deal with it, that the process is there to help them. Treatment, so how do we make sure that we're efficiently transferring out to the treatment centres, that we can contact them when we need to and that we get an answer back quickly. I'll give you a quick case study here of the difficulties that we have with one patient that covers all 3 of these. Very early on when we were having these conversations with our staff, there was a community member of a district Macmillan nurse, and she'd been working with a patient out in the community and actually suspected MSCC herself. She tried to refer that patient into the hospital and no one in the hospital wanted to know anything about it. No one would accept the patient and no one would acknowledge her concerns. For 5 days she visited that patient every day, watching the patient deteriorate. She spoke to her own hospital trust, acute medical teams, oncologists. She spoke to 2 different treatment centres to try to get advice and help for this patient, and actually hit a brick wall at every step. There was no guidelines, there were no processes there to help her, to help this patient. Eventually the patient was accepted in, was assessed, was MRI scanned and found to have MSCC, but unfortunately too late for anything to be done about it. Now this isn't an individual case, this was happening many times within our own area. When we start to talk to other hospital trusts and other centres nationally, you find it was actually a national issue that was going on. Because the condition is so rare, it's very difficult to pick it up and there were no processes in place to do that. So those 3 areas, early detection, early diagnosis and treatment, were really important for that patient. We knew that, taking that patient as an example, we needed to improve on those 3 areas. There's also an area of care and rehab. The NICE guidance suggests that the earlier that we get rehab involved, the better the outcomes for the patient as well. Referrals to rehab services were going in kind of very late in the day, so we wanted to improve on that as well. And then there was a fifth section, a final section that we put in about assessment and improvement. So how do we know that what we're doing is working? What have we got in place to monitor what we're doing and making sure we're improving? So we had this very simple kind of RAG matrix. Where are we at the moment with each of these stages? And by kind of compartmentalising all of these improvements that needed to take place, it gave it sizable chunks of people, so they felt like they could actually kind of attack it. And in many cases it's different people doing different pieces of work within this pathway, going away, coming back together and reporting on what they've done, getting help from their peer groups across all the trusts and then the treating centres as well. I think as with any kind of service improvement work that you do, once you start looking, you realise that a lot of the problem is the things that happen that don't need to happen, or the things that aren't happening that should happen, which all comes down to kind of waste. we removed an awful lot of waste in this process. Here's just a couple of examples. When the patients came into A&E, one of the things that prohibited their MRI happening quickly was that it had to be requested by a senior consultant within the A&E department, had to be requested through to MRI, they had to kind of consider it for a while, it wasn't within their protocols for urgent MRI, so we removed all of that waste. We brought them into the process so they understood why it was really important for these patients to have MRIs. We used a lot of case studies and gave them specifically to the areas where almost had failed that patient. So for imaging, we found a patient's pathway where there'd been a massive delay on imaging accepting that patient, and we case studied that patient. This is what happened, this is where the patient had good care, and this is where the pathway fell down, and we failed the NICE guidance, and we failed that patient really. And this was the outcomes. This is physically what happened to this patient, and by doing that with every different area, it kind of allowed them to see that their small part in the journey actually makes a massive impact on that patient's experience. So we removed that. We got imaging to accept that the request could come in from anyone as long as it kind of ticked certain boxes of symptoms, and they now see those patients urgently for us, and often before the patients have even hit the hospital they've accepted that MRI request. The issue of imaging, as I say, continues passing on the images out to the other trusts. The PACS managers within the trust are responsible for accepting those images. Now, they're very protective about the memory in those computer systems. They don't want to accept something until they know that that's the correct patient, that it's the correct image, that we really do need it. And this was causing massive delays on the surgeons, on the oncologists seeing those scans. So we got together with the people that support us with this IT system and said to them, how can we make sure that the people that are on call that need to see these images can see these images immediately without kind of conversation. And it turns out that they both the treatment centres had an element within their package that allowed them to view online but off-site, off the actual system, which means that the radiographers, the oncologists, the surgeons can actually put that patient in and draw that image up, whether they're sat in their living room at home or whether they're sat in the hospital trust, without having an impact on the hospital system. That already existed, they just weren't aware of it. The waste removal from just making them aware of that and an hour's training, this is how you do it, has been phenomenal. Not only are the images accessed quicker, but it's freed up a lot of time for other members of staff as well that were having to kind of act as middlemen in that process. Transfer to trauma and orthopaedics, these patients were seen as spinal patients, therefore when they came into the trust they weren't held by our acute medical unit pending diagnosis, they were transferred into trauma and orthopaedics, which obviously has the delays that admitting and waiting for beds brings with it. That has now changed for us. The patient remains on AMU until the MRI is done and the diagnosis has been confirmed. Obviously now that happens a lot quicker, that's not such an issue. They're not holding acute medical beds for a long period of time because they're happening within hours rather than days or sometimes weeks. And the biggest waste through all of this is kind of time. A massive amount of time has been removed. I mean, the one example I've put here is hours or days to contact the correct professional and get them to have to issue treatment plans for these patients. One patient I remember looking at early on sat in our acute medical ward for 4 days, was transferred to trauma and orthopaedics for 2 days. Our acute medical team became aware at this point that this patient needed to kind of be moved very quickly. Their awareness was building. They were constantly phoning the treatment centres to try to get a decision on this patient, all the while nursing this patient flat because they don't know whether they can move the patient or not. They haven't been given advice and they've been given no treatment plan for that patient. Both treatment centres now have a single point of contact 24/7. So whatever time of day or night, the consultants or whoever's looking after that patient, the MSCC coordinator for the patient in the receiving centre can contact that treatment centre, and the vast majority of our patients, 99% of the patients, are getting an immediate treatment plan within the hour, either there on that phone call if they're speaking to the right person that can make that decision, or they'll then go away and speak to the seniors and look at the images, and it's happening within the hour. So a massive waste removal there that's obviously having a great impact on the trust, because we're not holding these patients in the hospitals for long periods of time, but on the patient and importantly on their outcomes, because that's what we're kind of all here for. One other element that's helped us is standardization. Now this kind of happened in many different ways over the time. As I talked to you earlier about awareness, and the patients weren't aware of this condition, and I went into MDT meetings and gave senior clinicians the information about their patients that they didn't know previously. This is how many patients you've got that's had MSCC that sits in your cohort. And we talked to them about giving the patients MSCC information at the point of metastatic diagnosis. To which early on we had a lot of objection to this. They have enough bad news, they don't need this extra stress, etc., which you kind of have to take on board. So what we decided to do was to create for our network patient and staff information cards. So it normally happens now at the second point, so not at diagnosis but at their next appointment. The card is given to the patient with a conversation about, you know, this is very rare, it may not happen, but here are the signs and symptoms to look out for, and you need to act quickly, and this is what you should do. It's credit card size, put this into your purse, into your wallet, and when you need it, it's there. To complement that, we made a staff alternative, so all of our community staff have them as well, so that they can easily, you know, they haven't got to go back to the internet to have a look at what the signs and symptoms are or what the pathway is. They can see that for themselves there. And we also issued it out to all of our GPs in the area as well as speaking through our GP group. That card also goes out with the GP letter to any patient that now has a bony mets diagnosis. So for each patient from here on, they receive information that that patient's at risk. So if the patient walks through the door and says, oh, my back pain's getting ever so bad, hopefully we'll have had an impact on the GPs to pick up on that and refer into A&E. And the other side of the standardisation is about pathways and guidelines. They're very easily accessible now on our website, which you don't think is kind of, you know, a major thing. Do people ever look? But when you need it and it's not happening quickly, we had a lot of evidence of medical staff struggling because they didn't know where to send these patients. So they're all there now. And they've all been agreed through our network group as well, so we know we're working to the same standards across all of our trusts in our area. So here's just a few of the results to share with you. As I say, there's been many, and for me the biggest win is to see the patients coming in the door and receiving their MRI, having their treatment and going out quicker than they were diagnosed previously. On my board downstairs I've got the example of the case study that I talked to you about from previously and one from post-improvement. The post-improvement one, the patient had his information card and realised that it was very similar to the symptoms that he was experiencing himself. So when his community nurse came to visit him, he shared his concerns with her. She rang through to the MSCC coordinator, the AOS nurse in the hospital, and she agreed that the patient should come in urgently and be directly admitted to our acute medical unit, which she organised. By the time the patient had come in, the MRI was already booked. He was in an MRI within an hour and he was in the treatment centre having his treatment that afternoon. So, you know, within kind of 14 hours of the patient even making contact, he'd actually been in, had his scan, had his diagnosis and started his first round of treatment. And that's phenomenal turnaround to what we were seeing previously, where we had cases of up to 57 days for that to happen. So to happen in 14 hours is a huge improvement. But on the whole, our time from suspicion of MSCC to the request of the MRI is reduced by 84%. This is across these figures here are for our initial trust that we work with, and our other trusts are kind of working towards that now. It's been a gradual uptake by the different trusts. Time from request of MRI to completion of scan has reduced by 98%. Time from referral to receipt of treatment plan, which is what I was talking to you about earlier, is reduced by 99%, but in the vast majority of cases it's at the point of contact. And our average response time now has reduced from 16 hours to the point of referral. So time-wise, we've seen kind of massive scale improvements with the work that we've done. So I've put there, what better than to share that learning with others. I think we've seen our own growth. We started very localised, looking in one trust and the 2 treatment centres that needed to work with it. We realised early on that we needed to spread that across the region if we were to see the true impact, because of the fact that we have to communicate with these other hospital trusts. And recently, towards the end of last year, we held a national MSCC event where we presented some of the work that we'd done and the outcomes that we had, and we had many of the clinicians that had been involved in it there, and they were able to share that. And that was very well received. Nationally, it's a problem. Our MSCC coordinator from our initial trust has already visited 3 other hospital trusts across the country to help them with their pathways. I've seen 2 myself, and I've got another one booked in for next month. So people really are needing this support. So it's fantastic to see the work that we have done be nationally spread. And like many much lean work, it's no rocket science. It's just kind of getting the right people in the right places and getting the processes working. And this is my end slide, because we have happy people now. I was talking to the manager of the A&E department recently, and she talked about the massive impact that this work had had on them, not only for MSCC but other areas of acute cancer work that we're doing. And it's important to note that not only the patients are happy now, we're having fantastic outcomes for these patients, which is brilliant, but the staff are a lot happier as well. In A&E, they have somebody they can call if they have a patient and they're not sure. The community staff have a point of contact. They're no longer fighting the fight themselves in the patient's home. They have that kind of point of contact in the hospital that they can speak to. We have the single point of contacts in both of the treatment centres, which is crucial. So it's a much better working environment for the staff that are trying to help these patients, as well as for the patients themselves. That's it, thank you.
It was a fantastic presentation, I really enjoyed it, and I just thought, I'm sure there must be some cost savings as well attached to that. And I know in our area everything's about QIP and doing that to actually get it cost.
Absolutely, and I had this debate myself when I was writing this presentation about whether to put cost efficiencies in there, and it's kind of been an issue throughout the whole thing really, as to how to kind of depict what we've done. I'm always very hesitant to do it because it's very, very difficult, and I think this is true across the whole of the NHS, to actually quantify what you've done. And I'm hesitant to say we've made cost savings that I can't evidence, because the data collection side for MSCC patients was so poor previously, and I mean poor to the point of non-existent. To gain a baseline is virtually impossible. We know we've made cost efficiencies, I have no doubts about it. We did some very coarse work with our first trust that we were working with, because we're much further down the line with them. And for acute oncology as a whole, which encompasses MSCC and you know, other kind of acute conditions as a condition of the cancer or the treatment, we know that we've reduced length of stay for those patients by about 5 days. I suspect that for MSCC patients, that they're on the wider end of the scale. It's more like 8 to 9 days for those patients. But because we can't identify how many patients, that's 4. So we had kind of rough estimations of 300,000 savings in bed days for that trust, which you think with our dealing with 4 trusts, that's a massive amount of savings. But that's not the only cost savings, because on top of that, these patients are going out with better outcomes. The cost of care and rehab for the patients that were left paralysed was very significant previously. So kind of the reduction in care and rehab will have had a massive cost efficiency as well. And it's what we need to get better as an NHS, is to prove kind of what we are saving, I guess. But it was an intentional thing not to quote figures to you that I couldn't hand on heart say are solely to do with the work that we've done, because there is a lot of work that we've done for acute oncology. This is really an element of that work.